afternoon. Buenas tardes a todos. It's a pleasure to be here with you. I actually thank the IAS for having invited me. And it's a privilege, of course, to be here with my colleague, Dr. Tony Fauci. And it's also a privilege to be here with my sister, Patricia Volkov, who has been devoting her life to treating patients with HIV. I am working with substance use disorders, and I came to HIV because this is one of the consequences. She came through drug use because among people with HIV, many of them got infected through the use of drugs. And in fact, we do know, and we have known for a long period of time, that drugs have played a role in the infections from HIV. In particular, injection drug use is associated with a much higher risk of infections of all types, including hepatitis C and HIV. The contribution overall currently of injection drug use to new cases of HIV is approximately 10%. However, this varies geographically, and in some countries the contribution is very high, as is the case of Russia or Brazil. Now, as mentioned by Dr. Fauci, there has been globally a decrease in the new cases of HIV. However, this has not been the case for injection drug users, where in fact the incidence of HIV is increasing. And I think that this is something that we need to pay special attention because it should target our efforts to not neglect these populations. Now, what happens in the United States? And in the United States also we had seen significant decreases for many years of the incidence of HIV among injection drug users. However, this may be changing. And what is bringing this change? Well, the opioid crisis. The opioid crisis in America has been devastating, and it has been predominantly the devastation has been predominantly identified because of the enormous amount of people dying from overdoses. So in 2017, for example, there were more than 70,000 individuals dying from an overdose. And you can also see how rapidly the numbers of deaths have escalated and how they have distributed throughout the whole United States. The maps that you're seeing there are overdose mortalities per 100,000 individuals. And you see from 1999 to 2016, a dramatic rise in deaths. However, the opioid crisis has also brought about a significant increase in injection drug users. And you can see from data that has not been published that between 2002 and 2017, the number of heroin injection drug users in the United States has tripled. So what are the consequences of this increase in injection drug use with respect to infections? And it is clearly recognized that this increase in injection drug practices has been associated with an extremely fast increase in the incidence of hepatitis C. So what are the consequences with respect to the incidence of HIV? And I cannot say that this increase in injection drug use among heroin users has resulted in the United States on an increase in HIV. And I cannot say that because we do not have, as of now, current centralized data that is recent of 17 and 2018 or 2019 of the new cases of HIV among injection drug use. However, what we are very aware is that there have been outbreaks of HIV among the counties that are badly affected by the opioid crisis. The most notable of them was Scott County, Indiana. That resulted in 215 cases, HIV cases, from injection drug use in 2014 and 2015. And this, by the way, was due to the fact that they did not have needle syringe exchange programs. This should have not happened. And what we are observing now, and these are reports that I actually was able to dig out of newspapers, so the accuracy of it is probably not precise, but it's also likely to be an underestimation. You can see across many of the counties, some of them corresponding to counties that the CDC had identified as being at high risk for an outbreak of HIV, such as what we're observing in Philadelphia, Northern Kentucky, or West Virginia. But others are appearing in counties that the CDC had not identified. And the risk for identification of those that are greater risk are due the number of injection drug users, do they have needle and syringe exchange programs? Do you have treatment for individuals with opioid use disorders? So why this behavior? Over many years of research, we have come to understand clearly that drug addiction is a disease of the brain. We have also come to understand that it disrupts multiple circuits that are fundamental for everyday choices. In the person that's addicted, for example, there is a significant downregulation of the systems in the brain that enable us to perceive rewards and motivate our actions. As a result of that, people that are addicted actually seek that drug because it's the only stimulus that can activate it. In parallel, as you can see in the lower part, the left corner, there is a downregulation, dysfunction of the prefrontal areas of our brains, which are necessary for self-regulation and control, which explains why people who are addicted, even though they don't want to take the drug and they recognize its negative consequences, cannot inhibit the strong desires to take them. So what do we do? Well, addiction is a disease of the brain, but it can be treated. And we're very fortunate in the case of opioid addiction that we have 3 different classes of medications that are very effective in treating individuals with an opioid use disorder or opioid addiction. I'm going to be using terms interchangeably. There are 3 different classes. The oldest one is methadone, and this is a drug that, like the other 2, binds to the same target that binds heroin, the mu-opioid receptor. And when it binds it, it's basically described as a full agonist because it produces maximal intracellular signaling cascade. This is a drug that requires daily dosing. The second type of drug is buprenorphine. It is described as a partial agonist at the mu-opioid receptor because even though it has a very high affinity to bind to this receptor, the intracellular signaling that it engenders is 50 to 40% smaller than that produced by a full agonist. And this is a drug that can be given depending daily or on an extended release formulation. And finally, naltrexone is an antagonist for the mu-opioid receptor. It binds with very high affinity to that receptor, but it produces no intracellular signaling cascade. And thus, it prevents any pharmacological effects of any opioid agonist. These medications, the 3 of them, have been shown to be highly effective on a wide variety of parameters. They decrease drug use. They basically prevent overdoses. You are 2 to 3 times less likely to die of an overdose if you are on a medication than if you are not. And they significantly improve outcomes on infectious diseases. And that includes they prevent HIV, they prevent HCV, and they improve the overall outcomes of those in people that are infected. So to the right, you see a meta-analysis actually that was done in different continents that actually shows the effects of medications for opioid use disorders, these 3, buprenorphine, methadone, or naltrexone, in reducing HIV infections by 54%. And so medication for opioid use disorder is also a prevention for infection because it's preventing you from injecting drugs. And this data also shows its effects when someone already has HIV and is addicted to opioids and is given the medications for opioid use disorder. It significantly increases the likelihoods that they will be on antiretroviral therapy. It increases 2-fold the adherence on antiretroviral therapy, and it increases by 45% the odds of plasma viral suppression. So we have very powerful tools to actually help those individuals that are addicted to opioid use disorders. And this is fundamental too, because if you want, as was presented eloquently earlier by Dr. Fauci, if we want to retain people on antiretroviral therapy, if they are addicted to opioids, the way that we're going to succeed is by treating them with a medication for their opioid addiction. Otherwise, the risk of discontinuing the antiretroviral therapy is extremely high. So, if we have these tools, why not apply it? And there is, of course, always the academic theoretical concept and then the reality of what we are facing. And you see geographically, what you see in that map is that different countries, in terms of whether the extent to which they have access to these medications for the treatment of opioid addiction. In purple are the countries that provide those medications, and in gray are the countries that do not provide these medications. And what is striking is how many countries are in gray, despite the fact that the evidence show that these medications are very effective. Now, the United States, which is in the middle of the purples, which actually provides medications for opioid use disorders, not completely. There are many patients that don't have access to it, but nonetheless, there are many places where they can get treated. If you extrapolate that into the cascade of care, like you do for the HIV, you can see that in the United States, the gap between what we want to achieve for the person that's addiction, that is initiate them, screen them, diagnose them, initiate them on medication, retain them in medications, and lead them to recovery. There's a horrific gap there. So our challenges is how do we make this possible? Now, again, you are trying to change a culture on the one hand and to provide an infrastructure that will enable you to do that. In this respect, one of the strategies has been, and in the United States with the opioid crisis, it has rapidly been recognized that we do not have enough treatment programs, specialized treatment programs for addiction to take care of the enormous amount of people that have become addicted to these opioids. But we need not rely on specialized treatments. There's no reason why we cannot use the healthcare system to screen and deliver treatment for individuals addicted to drugs. And now we know from multiple independent studies that when the healthcare system, and in this case I'm showing you data from primary care physicians, actually provide the buprenorphine to their patients with an opioid addiction, the outcomes are as good as those that you obtain when you are in a specialized treatment program. And this actually makes it much more sustainable. The other setting that we have to actually expand our ability to identify and treat people that are addicted to opioids with or without HIV is the prison and jail system. And we know that individuals that suffer from substance use disorders are much more likely to be incarcerated. And in no way do we condone incarceration of people because they are addicted. Addiction is a disease, it's not criminal behavior. But despite that, these individuals are much more likely to end up incarcerated. The prevalence of HIV in prisons and jails, at least in the United States, is 3 times higher than that in the community. And if you initiate treatment in the prison or the jail system with a medication for their opioid use disorders, you significantly improve their outcomes in terms of them being able to sustain the treatment and recover for their addiction, prevent them from dying, and you also improve their outcomes if they have HIV. And so I'm illustrating, I just chose a paper that was recently published in which they show the difference on sustaining viral suppression when the individual leaves the prison or jail, which usually improves their viral suppression because they are given medication, but once they are released, they lose it due to relapse, to drug taking, homelessness, and low linkage to care. Well, models of care, just as simple as this one, you initiate the medication, in this case an extended release formulation of naltrexone, 1 week before the person leaves the prison or jail. 1 week before they leave it, and you follow them 6 months later, and you can see a very dramatic difference in outcome as opposed to just referring them to treatment. So medications work. But as it's the case for the HIV and the recognition that having to take a drug on a daily basis actually is not necessarily always makes the patients always compliant, the recognition that extended release formulations or long-acting formulations actually improve compliance has led us to focus our research in part to help develop formulations that will make it easier for patients to sustain treatment and not relapse. So there are treatments, extended release formulations for naltrexone, the antagonist, and there are treatments, extended release formulations for buprenorphine, once a week, once a month, every 6 months. And currently researchers are working for an extended release formulation of methadone. These extended release formulations will also make it easier to reach difficult to reach populations like rural communities, and will make it also much more acceptable to the justice setting where there is fear that medications may be diverted. So yes, we have a lot of evidence. We do know that syringe and needle exchange programs are very effective in preventing HIV among injection drug users. We know that medications for opioid use disorders are very efficient in preventing HIV and improving actually viral suppression, which in turn will lead to actually decreasing infectivity. We also know that treating with antiretroviral therapy, regardless of CD4 count, can lead into viral suppression, will be prevention against HIV. And we need to implement it. But if we ask ourselves the question, how do we prevent substance use disorders? I think that we need to turn into socioeconomic factors that we have to address. And I decided to finish my talk with this picture. It's a picture that you don't see in a scientific paper, but I think it tells us a very powerful story. And this picture, which was taken recently as part of the opioid crisis, attracted my attention not just because of the harshness of the environment, but because of the loneliness and isolation of this individual. And it is that loneliness and isolation and the lack of alternatives and possibility of change that perpetuates the use of drugs, that makes people vulnerable for drug taking. Now, how important are those social factors? And I'm using an extremely simple experiment that gives you an incline of how relevant they are. This is a study in which basically, like many others, uses rodent models, rats, in order to investigate the extent to which they will be administered different types of drugs of abuse, and rats actually administer drugs. In this case, they trained the rats to press a lever in order to get heroin, and the rats readily press the lever to get heroin. But then the investigator changed the equation. Instead of only giving them one lever to press and get heroin, they gave the rats a choice. They could either press the lever and get heroin, or they could press the lever and get the opportunity to have a social contact with another rat. And when the rats had a choice, they stopped taking heroin, and instead they pressed the lever that enabled them to have the social contact. So it prevented heroin administration. However, when the social contact was penalized, such that when the animal pressed the lever and there was an electric shock delivered before the animal had the chance to interact with the other rat, then heroin taking went up and social interactions were down. So the message here is that if we want to prevent substance use disorders, and if we want to improve the likelihood that people recover, our society has to provide a structure that will enable people to have minimal social interactions, to have opportunities, and to have choices. Thanks very much for your attention.